Well, good evening. Thank you all for coming here tonight. I'm Dr. Robert Harrington, and we're going to be talking about hip and knee arthritis. So the topic is hip and knee arthritis, and what I want to do is just talk a little bit about what is arthritis and how it affects us, and some of the things we can do to help out. My practice is largely about arthritis, hip and knee in particular. And Denise Burnham, she's a physician assistant, she's working with me, and she prepared a really nice handout that goes over a lot of non-surgical treatment options, and I hope you all had an opportunity to get that. It has a lot of good information. So let's get rolling then. Now, arthritis is basically a wearing away of the joint lining. And it can happen through a variety of different causes. The most common cause is osteoarthritis. That's that wear and tear arthritis we all get. Just over time, our body, wears down, the cells die, they have to be replenished. Unfortunately, the cells in the joint don't do a very good job about restoring themselves. They have a very limited capacity to heal. And that's why, with time, we start to lose the lining of the joint. Somewhat of what you see in this diagram, that's a knee. And usually the joint lining is a nice glistening white surface, looks like a cue ball. Or you've probably all seen the end of a chicken bone. That's that kind of smooth, almost rubbery tissue. That's cartilage, and it's mostly avascular. That means it doesn't have a blood supply, and so it heals very poorly, if at all. And with the passage of time, you start to have a wearing down. It gets thin, you can get exposed bone, and that can cause the problems that we all experience. So that's primary osteoarthritis. That's the thing that most of us get. There are other forms of arthritis. Inflammatory arthritis. I don't know if anyone's heard of or seen people with rheumatoid arthritis. That's an example of inflammatory arthritis. That's a different process where the lining of the joint, called the synovium, actually causes a destruction of the cartilage, and that does that in response to immune triggers. It's somewhat of a complicated disease process. Also, at times we see people who've had injuries, traumatic arthritis, say a fracture around the knee joint. And there are some more uncommon causes where there's a change in the biochemistry of the joint lining cells that can lead to arthritis, or sometimes there's a lack of blood flow that can lead to arthritis. So here's what I was referring to, what a healthy joint lining looks like. It looks like just like a cue ball, and it's nice and smooth, and has a very low friction. And this is what you want to see, but unfortunately this is not what we see as we mature. This was an arthroscopic picture, and this is just another illustration of the contrast between the normal, which I think you can see, and the arthritic. And if anybody has questions while we're talking, just raise your hand. It's informal. I want you to understand what I'm saying. And this is a slide of what cartilage looks like when it starts to get wear and tear. You can see on the top it's nice and smooth, and it's layered there, and this does a great job of absorbing shock, creating a very low friction bearing surface. However, as these cells mature and they age, they die off, and it's replaced by this roughened area. You start to lose the protective layer. It gets thinner. And with time, that can lead to the symptoms of arthritis. This is an illustration of that other type of arthritis I mentioned, inflammatory arthritis. That's people with rheumatoid arthritis, and that's where that red tissue is called synovium, invades the joint lining. It's a very unique process, and it's more of a disease as opposed to osteoarthritis is just wear and tear. But the net result can be the same. It's a loss of the joint lining. And oftentimes with people with rheumatoid arthritis or systemic inflammatory arthritis, systemic means it's involving the whole body, they'll have other joints involved, typically hand deformity, could be involving the ankle, the foot. And we mentioned that the causes of osteoarthritis are age-related, and some of the factors that play into that is decreased strength. What happens to us all as we get older, and I put myself in that category, we start to lose muscle mass, we lose strength. Those muscles are key in terms of supporting your body, and particularly your joints. They're like, the analogy I give my patients is they're like your shock absorbers. What happens if your shock absorbers were shot? Your front end would be gone, you'd be doing all kinds of repair work. So the muscle strength is very integral in terms of supporting the joints. And most people don't even think about that. Also, flexibility diminishes as we get older. We get tighter. And that means that the joint has a smaller excursion. Instead of moving over a broad surface, it has a very limited surface. It's mechanics, more force per unit area. It's going to accelerate the wear. And in our population nowadays, we have mechanical overload. I guess it's another way of saying, it's the obesity thing that's going on in the country. Well, not this country, the world. And that plays a big role because it's, as I said, it's mechanics, it's force per unit area. And your body is like any material, it has a yield point. You put so much force beyond that, you'll start to have a failure mode or breakdown. Just like anything, metal, wood, it's the same process. Some people just through what they do in life, have too much stress on it. And at times there are genetic contributions to arthritis, just their body biochemistry, the alignment of their limbs. So here's somebody who's fairly young, but they have quite bowing of their legs, and that's going to produce an abnormal stress, this thing's working, right on that joint on the inside part. They're going to get arthritis here because there's just too much force. It's not being evenly distributed. That's not so common, but you do see this same pattern of the shape of someone's legs even as with age and collapse of the joint space. Here's the big one, in more ways than one, obesity. I mean, we have just an increasing number of people who are overweight. And I read this statistic. Here's a graph that just shows the number of people who are obese, and it's gone from about 10%, I don't know if you can read that slide, in the 60s to up to 35% nowadays. That's a big change. And I think everyone knows why this has happened. We've become a less physical society. We've had some great innovations in technology, computers, that sort of thing. As such, we're just not as physical as our parents and our grandparents. And so we're more sedentary. We're just less active. We're sitting at a computer terminal all day, and we just don't get out and do things. And our food is, we don't grow it, we don't farm it as much as we used to. For a lot of reasons, this is happening to the U.S. and to the world. But that has a direct consequence on the development of arthritis. I read a statistic that for every pound you have, it's 3 pounds of joint force. So if you gained, say, 20 pounds, that's 60 pounds extra every time you put a step on that knee. 60 extra pounds. Yeah?
Harrington, on the hands with arthritis, you said that's inflammatory? Could that be osteoarthritis?
It could be. It could be. I just showed that was the one hand thing that was a typical presentation of rheumatoid arthritis, but certainly that does happen with osteoarthritis. But the hands aren't like a load-bearing joint like the knees are.
Not as often.
Well, no, it happens, but it's not as symptomatic. Yeah. And a repetitive overload. Here's a mogul skier. And that's probably why you only see young guys doing this. You couldn't do this, after, a certain age. Well, you could, but it would be pretty painful. In certain sports, endurance sports, I run, and I love doing things like this, but, marathon running is probably a lot more stress than your body wants to put up with. And it's just that repetitive pounding can lead to wear and tear injuries. So I just want to talk about some of the changes structurally that happen with arthritis. We mentioned loss of the thickness of the joint surface, the cartilage, and on x-ray there are some fairly characteristic things that I see that typify arthritis. One of which is the formation of osteophytes or bone spurs. Sometimes you see a cyst, that's a little cavity just below the joint surface. And we mentioned tightness of the ligaments and muscle atrophy. The ligaments get tight because when people have pain, they don't want to move that limb because it hurts. And then consequently, things tighten up, and that compounds it more because there's a smaller area for that joint to move. So it's like a vicious cycle. Here's an x-ray of a hip that shows some of those features I mentioned. There's some bone spurs, there's those little round cysts. I don't know if you can see that. Right up there. And there's increased whiteness. I didn't mention that. That's called subchondral sclerosis. That's just a buildup of bone in response to that added stress. But that makes the joint lining even harder and less able to absorb shock. So it's one of these maladaptive compensations that the body does. And here's a knee with the same kind of thing. There, you see some spurs on the edge of the bone. And you also see narrowing of the joint space. So here, there's a pretty decent joint space. There's still some of that cartilage left here, but look over here. Where's the joint space? It's gone. This is pretty advanced knee arthritis. This is somebody I would be thinking of doing something to help them out with surgically. So I'm going to go over some of the symptoms of arthritis, and first I'm going to talk about, what do people have with hip arthritis? And most people, I don't know about you folks, but when you say your hip, I don't know where you think it is. Most people think that their hip is just in this whole area. And the hip is actually right in the middle of your groin. The joint's right in the middle of your groin, right here. That's where your hip joint is. Most people think it's out here, a lot of different areas. That's where your hip joint is. And so the most accurate descriptor of pain coming from your joint is right in the middle of your groin, anterior thigh. And it can sometimes radiate to the knee. And sometimes people can have just knee pain. And the obvious thought in their mind is there's something wrong with my knee. And you have to be thinking that because of this way that nerve endings sometimes don't always correlate with where the real problem is, it can trick your brain into thinking that the problem is in one place, but it's really in another place. We call that referred pain. And we see that with the hip, we see that with the back. Oftentimes people with back problems have pain down their leg, not in their spine, down their leg. But problems with your hip, believe it or not, can present as knee pain. It can trick people. It can trick doctors. Sometimes we, advise, the wrong procedure. So it's always important to be thinking of the hip when you have a knee problem. Decreased range of motion, we talked about. That's that tightening of the ligaments. And people oftentimes have a limp, or we call that an antalgic gait. That just means a painful gait. You've probably seen people with a problem hip. They kind of lean to the side when they weight bear because they're trying to diminish the forces on that joint. They're not doing it on purpose. It's just the body tells them to do that. And as I said, you can confuse hip problems with back issues and with muscle problems such as trochanteric bursitis, and I'll show you some illustrations of that. So here's where people have hip pain, mid-groin. That's where the hip joint is. Out on the side here, sometimes people can have pain out there from their hip, but that's actually a muscle that inserts on the side of the upper thigh bone. It originates from the pelvis. It's a muscle that keeps the pelvis level. When you take a step, if you think about it, why do you not just collapse your whole body down? It's because of this one muscle that acts like a guy wire. It keeps it steady. And so if you have a problem either in your back or your hip, that muscle works overtime because the body says, we've got a problem here. You've got to keep things still so we're not getting a lot of extra stimulation. And so sometimes people get a compensatory overuse injury of that muscle. And usually it's like the tip of the iceberg. It's a symptom of some underlying problem. And it's at times hard to ferret that out. But that's not hip pain. That's what we call bursitis. And I bet some of you folks have had that. It's a pretty common problem. And that's that muscle I was referring to. Those are called the abductors, the muscles that stabilize the pelvis. And when people have back pain, a lot of times they'll feel pain right in that area, right above their butt area, and they think that that's their hip. But that's usually emanating from the back. It's probably a lot more common to have back arthritis and wear and tear injury. But people don't like to think they have back pain because it's a little harder to solve and it's harder to understand. But it's probably more common. I probably, for 10 people that come in with what they feel is hip pain, probably about at least half end up having a back problem. Certainly there's things you can do for them, but it's oftentimes mistaken for a hip problem. Some of the things that happen when you've got significant hip arthritis is you have a decreased ability to do your daily activities, such as getting up from a couch, like this poor fellow, trouble going up and down stairs. And that's one of the key questions I ask someone. I ask, can you get up and down stairs in a normal fashion? When people have bad arthritis, they can't do that. They have to take one step at a time, like a little toddler, one step, one step, one step. Whereas the normal fashion is one step after the other. It's just a compensatory thing that the body does to diminish that pain. They also have problems walking distances. When people have bad pain, they can't walk more than 5 or 10 minutes. And I was asking about, do you lean on a shopping cart? Because they do that. They kind of try to take the load off their hips or knees by leaning on a shopping cart. And sometimes when they're having enough pain, they have to use a cane to ambulate, to get around. And they have trouble putting on shoes and socks. That's another key question I asked someone. I said, do you have trouble putting on your shoes and socks? Because that can be an indicator of a really stiff hip from arthritis, or sometimes your knee. So now we're going to talk about knee pain with arthritis. And that's a little more straightforward in general than a hip pain because the knee is a more superficial joint. It's right there. Usually people know pretty much what hurts in their knee, and it's not as much of a cloudy picture. Maybe the front or sometimes the back of the knee. When it's in the back, it oftentimes represents a tightness or contracture of those muscles, and they become irritated. This is an interesting thing, instability. Oftentimes, well not often, but occasionally I see someone with really, really bad knee arthritis, kind of like what you saw in that slide, and they say, it doesn't hurt, but what they do describe is instability, where it just gives way, it just buckles, they collapse. And that's scary for patients, particularly in our winter months here, because you can fall, you can break your hip, you can just it's not good. And sometimes I actually end up recommending surgery even though they don't have a whole lot of pain, but they have that instability. Because who wants to just fall while you're shopping, have that give way? Not only is it embarrassing, but you can get other injuries. Occasionally you can get pain in your knee coming from your hip, as I mentioned, or sometimes the back. It can go down the shin bone. Some people have locking. That's where the knee is jammed in a static position. It doesn't want to move. And that's another one of those pain inhibition, I call that a pain inhibition mechanism. The body senses it's painful. It doesn't want to move because it's going to worsen your pain, so it just locks up. And we've talked about those functional limitations. So we talked about, the giving way. You can have swelling. Sometimes it'll jam up. Night pain, difficulty with stairs. You may use a cane, lean on the shopping cart. And I don't know if any of you folks have had these, symptoms. I suspect so. And here's where someone has pain at their knee. It's pretty straightforward. Your knee's right there. That's where it hurts. Sometimes it's one side more than the other. Typically, it's more the inner side. That's just how the mechanical forces with weight bearing are transmitted, more on the inner side. By that I mean here. It's usually the inner joint that's arthritic and sparing the lateral side. And that has some relevance when we talk about surgical options for, the knee. So, you guys with me so far? Do you have any questions?
If you have it on the outside of your knee, is that other than arthritis?
No, you can have arthritis there. It's just distinctly less common. The people with inside arthritis are typically bow-legged. When they're outside arthritis, they're knock-kneed. And that's just, it shows you where the joint reaction forces are. And actually, when it's on the outside, it tends to be a more aggressive arthritis. It, goes more rapidly. And usually I end up having to suggest doing something more often, and sooner in that situation. But it can be either. Okay. Yes?
What do you think of cigarettes?
We're going to talk about that. Yeah, it's a good question. Anything else?
Can arthritis cause a torn meniscus?
You can see that in conjunction with a torn meniscus, because oftentimes when people think of a torn meniscus, they think about a football player getting tackled midfield, but a lot of times it's part of the wear and tear process. And oftentimes I will have someone with some low-grade arthritis, and they have a torn meniscus, and they said, well, how did it happen? I didn't, fall, I didn't do anything. But with time, our body tissues become brittle, a little more brittle, and also there's that uneven wear. So usually it's the meniscus on the inner side. There's a theme here, on the inner side. What's that? Well, that can happen, but usually it's the inner side. And it's usually in conjunction with some wear in the joint lining also. But it can happen just from getting up from a car, getting into your car, getting up from a crouch. Just usually it's a squat pivot motion.
So it can just happen, and then when they have repair, when they're in there taking care of it, then you notice the arthritis, or?
Well, usually you have a pretty good indication that it's there, because we often, if we ever come to surgery, we often will obtain some imaging studies like X-rays, MRI, so we have a pretty fair idea that it's not in isolation. Okay, so we'll keep going. I don't want to talk too much because I know you guys will fall asleep, so I want to give you an opportunity to talk or talk about questions. Okay, so what are our treatment options? Obviously, you know what people do for arthritis. They take things like Motrin, Advil, Aleve, over the counter, sometimes Tylenol. They don't cause healing, they just take away some of the inflammation. This is inflammation. It's an injury response that the body has where there's swelling and there's increased blood flow. And these are anti-inflammatories. They just diminish that inflammatory response. The Tylenol, in distinction, is more just a painkiller. Glucosamine Chondroitin sulfate, those are, I don't know if anyone's heard of that, glucosamine chondroitin. If you have had any animals taken care of by the vets, they use it all the time. It works for them. But that's a nutritional supplement that actually is thought to help stimulate healing of the cells of the joint lining. Remember we talked about why does arthritis start up? It's because we don't have a very good ability to regenerate those cells. There is some thought that Glucosamine chondroitin stimulates a little bit of that rejuvenation of the joint lining. It's somewhat soft scientific data, but like I told you, veterinarians have been using it for a long time. And you know, your dog and your horse is not going to fool you. If it's helping, it's going to help. You know, they can't fake it. So I think it probably does help. We talked about injectables, and that's that Synvisc that you asked about. What is Synvisc? It's a protein called hyaluronic acid, which is a normal constituent of the joint lining cells. And so I think that part of the theory and why it was developed is that, I don't know, you want to close those doors? Is that, I think there's another meeting going on. There you go. So I think part of the rationale as to why it was developed is the manufacturers were trying to think of ways to temporarily recreate a normal healthy joint. And you know, perhaps it does that to some degree. It restores some of the lubrication, maybe a little bit of the cushioning in the joint. We're not really sure why it works, but some people get great results from it. Some people don't. It's hard to know who's going to get a good result and who isn't. We have patients that, you know, get a shot, a series of shots like this every 6 months or a year. They love it, and even though I have, you know, some pretty significant arthritis, that's all they want. Yes, sir.
Inject glucosamine?
I'm sorry?
Inject glucosamine?
I've heard of that. We don't. You know, most of it is pill. Yeah, I've read that, but we don't do that. Yeah. Yes.
Does fish oil help at all with joints?
You know, I don't know that, Barb. Have you read something about that?
Yeah, a little bit here and there. Fish oil, being helpful for joints.
Yeah. You know, well, I've heard of shark, something from a shark, but I think it's glucosamine chondroitin. Yeah. Yeah. Yes.
What about Synvisc or Euflexa? Do those injections help?
Yeah. Well, this is what we're talking about. It's a hyaluronic acid, and the difference is Synvisc, I don't know if you know this, is made from coxcomb, and Euflexa is the same. It's just that it's a synthetic. And we did have some problems with sensitivity reaction to the Synvisc, so we tend to use Euflexa more. But they're the same, you know, compound. Steroids, we sometimes will do a steroid injection. Has anybody had a steroid injection before? Did they help? Yeah, they help. They can be, you know, the duration of their benefit can be variable. Some people get benefit for months and months, some people it's short term, but they can help. They're just an anti-inflammatory medicine. They decrease swelling, and they can be helpful.
Are there any side effects with injectable steroids?
Good question. With diabetics, you can have a transient blood sugar elevation. And sometimes it can have an effect. You can get your blood sugar up high enough that it can cause some symptoms. So generally with a diabetic, I tell them about that. I say monitor your blood sugar, and I don't like doing more than one injection at a time. If you have repetitive injections over time, it actually can cause some thinning of the joint lining, even accelerate the arthritic process. So when someone, you know, has that, I tell them that, you know, we don't want to do this many, many times. Okay, that's a good question though. Yes?
What's the difference between the steroid and the Synvisc, which is a protein?
Yeah, well that's it. See, the steroid's just a pure anti-inflammatory medicine. It's like taking a powerful aspirin, putting it into where it needs to go. It'll take away the inflammation for a variable period of time, up to 6 months. But the downside is it can accelerate the wear and tear. So it's useful if, you know, someone's got bad arthritis and they know that, you know, they're going to want to get something done in 6 months or a year. You know, it's good for that. Or if it's just a one-time, sometimes, you know, I will offer a steroid injection because immediate effect, and it's, you can just do it right there. With the viscose supplementation, the Synvisc and the Euflexa, you have to oftentimes order it through the pharmacy or send away for it, because the insurance carriers are very finicky about that. We have to sort of do what they want.
Are the injectables just postponing surgery?
Well, sometimes they are. Sometimes they are, but sometimes they can have a fairly long-lasting effect. Some people can't have surgery for various reasons. Some people are just apprehensive. And sometimes I use it as a starter, because if I just saw someone, shook their hand and said, "You need a knee replacement," it kind of throws them off. They kind of have to get used to the idea of what's going on and convince themselves that they've done everything else. And that's how I sometimes use it and how I treat patients.
Is there a limit on how long the Synvisc should be used?
Not really. No, I mean, not as far as I know. I would continue using it as long as it's helping you out. It should give you at least 4 to 6 months benefit. If it wasn't doing that, then I wouldn't advise it. Yes?
Is it true that the steroid injections don't work as you get older? I had one last June with a doctor who used an ultrasound machine, and he said I had bursitis, and he gave me an injection, and it was wonderful for 3 or 4 months. That was June. Last December, I had one by another doctor, because the other doctor retired or something. And he didn't have that machine. He gave me some steroid injection. It didn't work. The next day, I had a severe headache. For a week, I was in worse pain. I called and asked him what happened. It worked the last time. He said, "It's because you're getting older."
So that made you feel pretty good, didn't it? Well, he might not have been in the right place. Sometimes you can inject the medicine in the wrong tissue, and that's why the ultrasound. But he was right in a way, or the doctor was right in a way. With time, they just don't work anymore because of the arthritic process advances, and it's just too profound for the steroid to have an effect. So, there is something to that. Okay. So we talked about injectable steroids, the viscose supplementations, that's the Synvisc, the Euflexa, physical therapy, strength, flexibility, balance. I think that's very important. Every time I see a patient, I really try to get them involved in a program of physical therapy. And sometimes it's just something that you can do on your own. Oftentimes I encourage patients to see the physical therapist just for like a 1 or 2 visit. Learn how to do these exercises safely and commit to them. That does wonders. Sometimes people have just horrible looking joints. They get into an exercise program, they become fit, and I'm out of business. They're healthy, they're good, and that's all right. Weight loss, that's important too. We talked about the contribution of weight to the development of arthritis. Activity modification, sometimes I have to tell people, listen, you probably shouldn't be running races competitively. You probably shouldn't be playing basketball because that's just too much impact load once you started that arthritic process. And that's a hard thing to accept. We don't like to contract our world. We like to do everything we always did. But sometimes you have to do that. So you're all familiar with Tylenol, Advil. They're helpful in the more earlier stages. Usually when people come to me, they've already been through this. And we talked about the glucosamine. It helps your dog. It helps us too. Whoops, let's go back there. These are the injectables, the steroid injections, hyaluronic acid, and glucosamine. Like I said, I don't do the glucosamine injections, but the first 2 we do. And physical therapy, low impact. So that's the key, is to find something you can do that you can tolerate. Because if you go out and do something and it causes worsening pain, are you going to want to do it? No. So you have to find a way or a medium to do exercises that you can tolerate. And that's where I think it's important to have a little bit of coaching, with a physical therapist. It needn't be prolonged, just a session or 2. So now we come to the surgical treatment options, and this is when the other things haven't worked. And so say somebody has a knee that's giving them trouble, some arthritis. One of the options would be arthroscopic surgery. Does everybody know what arthroscopic surgery is? Ever heard of it? It's where arthroscopic surgery is when we do a minimally invasive surgery with this structure called an arthroscope. It's a fiber optic telescope. We look into the knee and we can view the whole knee, and then through a small incision we can remove areas of wear and tear, damaged meniscus. Sometimes we can smooth down roughened areas of arthritis. It has a limited application, but sometimes it's very helpful in the earlier stages. Osteotomies, do you remember that one slide I showed with that person who was really bow-legged? I've done the osteotomies. That's where you actually change that angle from being bow-legged to just a little bit knock-kneed, and that redistributes the weight-bearing forces from the arthritic joint to the outside where it's not so arthritic. This used to be very, very popular probably 30 years ago, but with the advent of replacement surgery, it's fallen out of favor. Why? Well, it takes a long time to recover from something like this, and you ultimately, after about 10 years, end up having to have a joint replacement anyway. But this is an option in a young laborer, someone who was, say, in their 30s and they wanted to, downhill ski, rock climb, that sort of thing. But it's a very limited application. Fusion, this is even more limited. This was the historical treatment that your grandparents and your great-grandparents had, where they just make the bone solid, because we didn't have other technologies. So this is used very rarely. And arthroplasty, that's joint replacement, and that's something that you're probably more familiar with, the knee replacement, the hip replacement. Here's a picture of arthroscopic surgery. So we're looking into the knee, and you can see the area of the worn joint lining. Remember when we said that the nice, healthy cartilage is like a cue ball? Look at that, it's like crab meat. That's that partially worn out joint, and we showed that slide with the worn and the normal joint lining. So what you do arthroscopically is you'd take this device called a shaver, and you just smooth that down. And back here, there's a tearing of the meniscus, and you just trim out the torn piece, and that will help. Obviously, we're not curing it, but we're relieving some of the symptoms. Yeah?
Doctor, you can do the same type of surgery on the hip, right?
Yeah, the hip doesn't have the meniscus like this, and it's done much less commonly, but people do it. There's one of my partners does hip arthroscopy. Fairly limited application. You see it in the younger population, people in their 30s, 40s. But I actually believe a lot of that is just the first stage of arthritis. But there are certain patients that benefit from that. So that's arthroscopic surgery. And here's the osteotomy. That's where we take a little wedge of bone and change the angle to shift the wear pattern. Here we have knee replacement surgery. And this is what is probably one of the most common surgeries we do for arthritis. So what we're doing here is we're just removing that arthritic layer. We're not really replacing the knee. When you think of replacement, you're thinking, like you take a knee out of the shelf and put it in there. You don't. All you're doing is you're resurfacing the joint. You shave away the arthritic bone on both sides, on the femur, the thigh bone, and the tibia. And then we use bone cement, and we put a new cap on the end of the thigh bone. We put a plate on the shin bone. We use bone cement typically. And there's a plastic piece in between. We try to preserve the normal ligaments. Sometimes we take out these central ligaments to help with the motion, but we preserve the ligaments on the sides. We have to split the knee in the front, and then we repair all the muscles in the capsule in the front. But that's, in a nutshell, what a knee replacement is.
Don't some replacements keep your own kneecap?
Yes.
Why do they do that?
Well, it's a individual surgeon determination. I tend to preserve the kneecap if it's not arthritic, because some of the problems I've seen after knee replacement, particularly when the kneecap's been resurfaced, people sometimes get fractures because it weakens the bone. And it's a debatable thing in orthopedics, but I think the weight seems to fall towards not resurfacing unless you've got arthritis. So if there's arthritis, I resurface it, but if not, if it looks pristine, I leave it alone. I don't think there's anything as good as what you were born with. So I try to leave it if I can. Now, we talked about the partial knee, and remember when we said how arthritis occurs usually on one side or the other, and typically on the inner side. And sometimes I see a patient just with bad arthritis on that inner side. The rest of it is pristine, it's great. It seems like a shame to, remove everything that's good and healthy. And with the total knee, we do take out some of the normal ligaments. And so the knee doesn't quite move as the normal knee does. It's a slight difference. Sometimes people, don't feel it, or they don't, notice it. They're just so happy not to have that pain. They don't care. But there is a slight difference in how it feels, how it moves. We call that kinematics. With the partial knee, you're not removing some of those key ligaments. So that's an advantage. It's also a quicker recovery. What's the downside? Well, once in a while, people will go on to develop, it's rare, arthritis on the outside joint or around the kneecap. And there's a higher revision rate for a partial knee replacements. At about 5 years, there's a 6% revision rate. That means you have to do it over again, compared to 1 or 2% for a total knee. So it's a little less predictable operation. But I think if you're experienced and you choose the right patients, it's a wonderful operation. People get better real quick. They don't go through all that stiffness and tightness that a lot of people get with a total knee. But not everybody's a candidate for this. You have to be the right candidate. You have to have isolated arthritis. But it's a wonderful operation if you're the right fit for it. And this just shows the incisions between the partial knee and the total knee. And the total knee is a little bigger incision, a little more soft tissue trauma. And that's why I think it takes longer to recover. So hip replacement surgery, that is where we remove the arthritic ball. So here's the replaced hip. We've taken out the ball. You cut it right here. And then we have an artificial ball. It's attached to a stem. It goes down the semi-hollow thigh bone. There's a cup in the pelvis. That's a hip replacement. Hopefully you guys aren't squeamish, So it's a great operation. It's probably the best operation we do out of anything in terms of enhancing quality of life. Because when people have hip arthritis, they're just devastated. They are so painful, and they're so grateful when they have this done. Day of surgery, we get people walking oftentimes, and they know it's different. They don't have that pain that they had before. They have some incisional pain from the cut, but they feel totally different. It's a wonderful operation. I don't know if anybody has heard about anterior approach to the hip. You have a question there?
When you do that hip surgery that you just showed on the screen, would that help alleviate the pain that's in the groin area too?
Well, yeah, because that's where you get that pain, is in the groin area. That's your hip joint.
But you're replacing that little ball, not the groin area.
Well, where you perceive pain, is over a broad area. And pain can be originating from the hip joint. Then there's secondary pain from adaptations to the muscles, the ligaments, and you can get pain over a broader area. It's not going to be just in that one little area right there. You're going to feel it over more of a broad area. The brain doesn't map out pain as precisely, as you would think. It typically is over a broader area. But it would take care of that groin pain, to answer your question. Okay. So I don't know if anyone's heard about anterior approach to the hip. I get a lot of questions about this. I think there's been some marketing about this. Has anybody heard about that?
I was just reading about it. I think it was on your website.
Yeah. Well, it's just a different approach to the hip. It's just making the incision in the front And you can go in the front, the side, the back. I usually do the hip replacements, and it's called the posterior approach. It's just it gives a better view of the anatomy, and it's a much easier way to do more extensive surgery if someone has to come back, 10, 15 years later to do what we call a revision. That's when we have to take out the old one, put a new one in because it's failed. But this has become very much in the news and press. They tout it as being a rapid recovery, and you're out of the hospital in a day or two. There's really no difference in terms of functional outcome at about, I think it was about 6 or 8 weeks post-surgery. Probably in the short term, there may be a little more rapid getting rid of your cane or whatever, by a week or two. But when you're doing this surgery, you want this to last hopefully a lifetime, 20, 30 years. And so in my mind, I want to feel confident. I can see what I'm doing. I want to put in the components in the appropriate way. And so it's whatever the surgeon's comfortable with. I'm very comfortable, doing it in this posterior approach that I've always done.
When I was reading online, it said there's a lot less, you cut through a lot less muscle.
Well, yes, the only muscle that really gets cut, it does split the muscles, and in the back, there's some small muscles that we cut, but we repair them. And like I said, the functional recovery, how they do, how they perform, no difference. But it has gotten the public's attention. People hear about it, and we love new things, and so we go for it. And you just have to have a discussion with your surgeon, and if they're comfortable doing the surgery through this approach or the back approach, then that's what you want to do, and they get good results.
How long are these hip replacements and knee replacements now? How long do they last?
Well, that's a great question. I didn't really get into that. We've had quite a advancement in the materials that we use, and they're much more durable. I've alluded to redo surgeries a couple times, revisions, and that happens when the components loosen. And they do that in response to the generation of wear debris, little microparticles of plastic and sometimes metal that circulate around the bone, and they cause an inflammatory reaction, and that causes some loosening between the components in the bone, and then they cause pain.
So the person with that problem, they'd be having pain.
Yes. And so then you have to take it all out and put a new one in, which is a bigger operation. It's more complicated, more complications. But we've developed newer, better, more durable materials. Ceramic. We've been irradiating the polyethylene, which makes it much more durable. So we're not seeing that wear that we used to. And which is nice because unfortunately, I'm seeing arthritis in younger patients than I used to. And the traditional teaching was you don't suggest a replacement unless they're in their 60s or their 70s. But sometimes people have crippling arthritis in their 50s, even in their 40s. What are you going to do? Just say, live in pain and suffer until you get to be 70 or something like that? That's not right. This is your most productive years. So I feel more comfortable in helping people out at a younger age if they have the appropriate indications. So there are better materials that we have nowadays.
Well, that's what happened to me, and I'm just wondering, being so negative.
Oh.
What's it going to happen to me?
Oh, yeah. Well, nowadays we could, yeah. So anyway, that's the anterior approach of the hip. A lot of people want to know what you can do after a joint replacement, and you can do a lot. Most people really don't have any functional limitations. In our mind, we like to think that we're going to be out skydiving and playing football, but we don't do that. We want to hike, we want to hunt, fish, boat, play golf, play with the grandchildren. You can do that stuff. You can play doubles tennis. You can cross-country ski, snowshoe. I even tell people they can go downhill skiing on the cruiser runs, the blue trails, swimming. But the theme here is you want to avoid those high-impact activities because we don't want your joint replacement to fail. If you push it hard enough, it'll fail. I don't know if you guys remember Bo Jackson. He's a guy that had the hip replacement, and he played football for the NFL. He played baseball. And he was apparently quite a talented athlete, but unfortunately he had, he had a dislocated hip playing football. He developed avascular necrosis. That's where the blood flow was cut off, and the bone just died, and he had to have a hip replacement. And apparently his mom said, I want you to keep playing pro sports. This is what I heard. And so he did, and unfortunately, within a year or two, it just fell apart. And so you really cannot subject these artificial components to some of those stresses. Like I told you before, there's nothing as good or as durable as what you were born with. Anything else is, it's a substitute, and it's good, but it's not the same. So activities to avoid: high-impact sports, running, pounding on it, playing basketball, court sports, field sports like football, soccer. Sometimes I let people play softball as long as they don't try to tear around the bases. Singles tennis. So there's a lot of things you can do, and people do have joint replacements, play doubles tennis, play golf. A lot of golfers, with total knees, total hips. And we touched on this a little bit. When would I start to think about offering surgery? Certainly I don't suggest it the first go around unless it's just, really end stage at that point. But if they have progressive disability, that means they have a increasing problem with just your daily activities. You have a hard time shopping. You have a hard time just getting up from a chair. And you'll know it when it happens. When you have night pain, that's a big one. When something wakes you up from sleep, that makes you want to get something done. That's when people are serious about getting something done. Instability, we talked about that. And when things, other options haven't worked out, some of the things we alluded to. And there's a tendency, because people are afraid of surgery, and it's understandable. It's an expensive thing. You're thinking about the pain and all the other things that can go wrong. And I think that, makes them afraid to seek out options that can really help them out. I think we've done a much better job with some of those issues than we have in the past in terms of pain management. We have well-established programs in conjunction with the therapist about enhancing and speeding up the recovery. So I think we do a much better job than we used to. And a lot of those concerns and fears are sort of based on historical concerns. Yes, sir.
What has been the average recovery time for some of your patients with total knee replacement?
Well, the hip and the knee are different. You can't compare them. The hip is a ball and socket. It's a movable joint, a lot of freedom of motion. We don't have trouble getting people moving their hip. The knee is different. It's like a hinge. It's just inherently stiffer. And that's what people have to overcome. They have to regain flexibility and strength. And I always tell patients that what I do is the easy part. We do them all the time. We're good at it. We can get reproducible results. The hard part is what the patient has to go through in terms of restoring their strength, their flexibility. Because if you think about it, arthritis develops over a lifetime. And you think you're going to have a new, muscle ligaments just from, an hour and a half in the OR? You're not. That's something that is a biologic repair process. It takes time. I tell people it can take up to 6 months to really recover from a knee. But having said that, I say most of the hard work is probably in that first 6 weeks. And everyone's different. Some people are just really, really tight. They have a harder time. Some people are more loose and they have an easier time with it. It's all variable, but usually it's in about that 8 to 12 week after a knee replacement. Yes?
The hip, the recovery is quicker than the knee?
Yes.
How long would you say would be replacement?
Well, I've had people walk out of the hospital just using a cane, but it's more in the realm of 4 to 6 weeks. You know, Barb could probably speak to that stuff. It's a lot easier to recover with the hip because it's just intrinsically a looser joint. Yes.
You don't do total knee replacements, do you? You talk about the lining.
Well, this is what we call, it's a misnomer. This is a total knee replacement, what I just mentioned. But, you know, it's basically, it's not a good description of what we actually do. It's a resurfacing, but it's what is considered a total knee replacement.
Why do they show sometimes, I don't know, Claude, but the guy came in and like a joint, you know, and looked like almost like he's going to stick in both bones. That isn't, you know, had a whole thing of metal.
Was that a knee, you mean? I'm not
So
sure.
it isn't that way, it's just a line.
Yeah, we just shave away the arthritis. Well, you know, that might have been a more profound defect. Sometimes people with tumors, you know, you have to, that's a total knee. You have to just resect the whole bone or really horrendous injury. So that's a little different, you know. But in a normal total knee, we resurface the lining of the joint. So it's not as, you know, traumatic or aggressive as surgery. And I try to stress that, you know, so that people aren't thinking that it's this horrendous, destructive operation. Yes?
Is it possible to do 2 knees at the same time, or do you just do 1?
Yeah, we sometimes do that. There's a higher complication rate. It's not greatly higher, but there's a higher complication rate in terms of blood clots, injury to your lungs, your heart. So I select people out. If they're healthy, no cardiac disease, no history of blood clots, and they're physiologically young, and what I mean by that is some people, you know, are age-wise, they're, you know, not that old, but they look old because, you know, their bodies are just aged prematurely. So they have to be physiologically young. I will do both knees at once. I try to talk them out of it because there is a higher complication rate. But sometimes people say, I've got to have this done. Particularly, you know, if they're working and they want to minimize the downtime.
During that 6 weeks, you said there's 6 weeks of, you know, recovery.
Yeah.
Time. Initially, is the person walking?
Oh, sure. We get you know, the therapists get patients walking. We like to get them up the day of. Yeah.
Is it outpatient or inpatient?
Well, it's inpatient. Yeah, yeah. There are some surgeons who are doing the partial knee replacements as an outpatient, but that's, you know, just very select patients, and that may come about. You know, that's probably reasonable.
I've heard of the striker knee and rotating platform knee, and I wondered if they're the same thing or they're 2 different things.
I use the striker knee. That's that get around knee. It's just a design feature. I'm not sure if that's vastly better than the other knees. I know it's got a lot of marketing. A lot of people ask me about it. I think it does, you know, it seems to be a little more stable, but all the knee designs are fairly comparable. The rotating platform knee theoretically was a great idea. It hasn't shown any benefit clinically, and if anything, some of the clinical results are a little inferior to the just standard knee. But that's where the plastic piece moves, you know, like the normal joint. So it seems like a good idea, but in reality, they have a harder time getting their range of motion with those knees. I don't use it. Yes?
I'm afraid to ask, but you know how you said some people don't have pain with the knee arthritis? And they may just fall, you know, they may lose strength or whatever, but they don't have a lot of pain. Does it always become painful after a number of years?
Not necessarily. I think just it's amazed me how each individual has a different perception of pain and, you know, what constitutes pain. And some people just don't have pain. But after the surgery, you know, I think they said, why? This feels totally different. I'm so glad I did this. Even though they said it doesn't hurt, you know, they just had that instability. So I don't think it necessarily would evolve into that. But the majority of people do have pain.
Would they have the surgery then if they didn't have pain?
because they're afraid of falling.
But if that wasn't a big issue and they don't have pain, but you know
Then I
the
wouldn't-
arthritis is in there,
I wouldn't do the surgery.
you do surgery.
No. I mean, how am I going to make them better?
Does it progress then, like in a number of years?
It can. It can. You can think of any different
Slowly or?
scenario. Right. Yes.
I heard that NSAIDs or read that NSAIDs are not good for you long term, especially elderly people.
That's true.
I'm sorry. I was on them 3 or 4 years now, and I was on diclofenac. That helped me for about 1.5 to 2 years. Then I went to naproxen, didn't do anything for me. Now I'm on Celebrex, not doing anything for me as far as pain, hip and knee. So I'm thinking, and I know it can destroy your internal organs eventually. How long? I've been like 3 or 4 years now. That's the maximum. I mean, should I keep trying other NSAIDs or should I?
No, I don't think there's any big difference between the NSAIDs. You probably just have, advanced, the disease is probably just progressing and it's just no longer an effective mode of treatment. They can cause injury to your kidneys, so diabetics have to be particularly careful. And anybody that is on them long term, their medical doctors have to monitor their blood chemistries periodically. But some people do take them for many years, but they have to be monitored and followed carefully. Alrighty. I don't know if I have any more. Yeah. Well, that's it.
Just one question. Can you tell us what's involved with the post-surgical rehab for knees?
Yeah. Well, usually when I see someone and I said, okay, I think surgery would help you out, and I go through the process. I oftentimes will have people go see the physical therapist beforehand to start getting ready for the surgery. They can start doing exercises, learn how to get around with a walker, crutches, learn some adaptive aids at their home that they'll need. I find that very helpful. It's called prehab. Then I would have them see their medical doctor to evaluate them and make sure they're not at inordinate risk for surgery, because this is an elective operation. I try to make it as safe as possible. I like to have them see, their cardiologist, if they have a cardiologist. I even have them see a dentist, because if you have, unfortunately, some of us, can't get to the dentist, and we have some teeth that are in need of attention. But some of the teeth that have cavities can release bacteria in your body, and if you have a fresh surgery, the bacteria likes to go where the blood flow is, and that's the surgery area. And so I always have them see a dentist if they haven't seen one in the last 6 months. So we've got that all squared away. They come into the hospital, day of admission, we do the surgery. Typically, people are in the hospital for 3 days. While they're there, the therapists get them up and they assess their ability to care for themselves, at home. They work on strength, mobility, taking care of themselves. We call that activities of daily living. And then most people will go home if they have a spouse or someone to help them at home. Some people go to what's called a rehab facility. That's like a halfway place between the hospital and going home, where you have nursing care. It's just not as intense a care level as at the main hospital. And that can be as long as 2 or 3 weeks, as short as 5 days. And then after that, or sometimes fairly soon after discharge to home, people start on outpatient physical therapy, and they participate in that for about between 6 to 12 weeks, depending on how rapidly things are progressing. Most people go back to work in about 6 to 8 weeks. Most people go back to driving in about 5 weeks. Most people stop using crutches, cane, walker at about 3 or 4 weeks. But that's it in a nutshell.
Do we have facilities around here that are near hospitals?
Well, here there's several. There's Rochester Manor, there's Colonial Hill, there's an acute rehab place on Pease called Northeast Rehab. In Dover, there's several facilities, Dover Rehab, Langdon Place, St. Anne's. Those are places that do the rehab.
They're rehab for joint replacements, not nursing homes.
Well, a lot of them are nursing homes, but they have a separate building or wing for the rehab patients. They try to.
Is it just a facility for?
Well, the one in Pease, Northeast Rehab, but that they are fairly specific as to what kind of patients they take. You have to, like a bilateral knee replacement, you could go there, or if you, I'm not sure, it's harder to get people into the Northeast place. But the local facilities, I think, do a good job, and I know, a lot of people give me that same look, but they really have made an effort to, spiff up their places, and, they have good therapists. I don't know, the gentleman in the back, you had a question.
I have a question. My wife over here was telling me what she has, what she's tried. Now, God willing, this week she wants to start going for either physical therapy or the pain management care center or stuff like that. What she's told you she has, you think that's all a waste of time? Or, you think stuff like that is going to help? Or it's just a waste of time?
You mean going to physical therapy?
Physical therapy or the pain management center,
Well, it's sort of hard to generalize. They do have a role. They can do a lot to lessen the pain so that you in turn can, benefit, from the physical therapy.
Can't walk well,
Yeah. Well, I suspect you probably have a back problem.
Nothing but back.
Oh, really? Yeah.
But the bottom line is, do you think these things can help her?
At times they do, but usually if it's your hip or your knee, there's usually better ways of dealing with it.
It's
Better ways to deal with it.
Yeah.
What ways? Surgery?
Well, at times, or these injections, the things we talked about. Yeah. But I don't know the specifics, so.
There's no real options to surgery other than NSAIDs or injections, and none of that is permanent, right?
Correct. But so it all depends on the level of the wear and the disability. And some people have a pretty low level of disability and pain, and they just say, I'm okay the way it is. I don't want to do anything.
So the bottom line is, I didn't get a straight answer. For what she's doing, you think it'll benefit her? You think it pays for her to go to these things?
I don't know, sir. I don't know your wife's particulars. I guess that'd be a discussion to have with the doctor that sent you there.
Are you taking new patients, by the way?
Sure.
Okay.
Yes.
What age do you stop doing knee replacements?
Well, again, that's at the chronological and the physiologic age. Chronologic age means just, how old are you really? Are you, say like you're 75, that's your chronologic age. Your physiologic age is how old your body really is, because some 75-year-olds look and act like a 60-year-old. Some 60-year-olds act and look like an 80-year-old. So they're two different. So even if they're older, but they're physiologically younger, I would do surgery. I actually had a patient who was, and I can't believe I did this, she was in her 90s, she was like 92, 93, something like that. But I did a knee replacement. I said, there's no way I'm going to do this, but I was talking to her and her family was there. She drives independently. She came from the western part of the state. She does everything. And she's somebody who was like physiologically 70. And she recovered great, and she's, really happy. But that's really an unusual situation. So there's no set age. There's no set age. I don't think I've ever done anybody in their hundreds. I don't think I will. Yeah.
After the hospital stay, does everybody go to a rehab, or is it?
No. Most people, and that's changed. Nowadays, most people don't go to a rehab facility, inpatient rehab. If you mean by rehab, everyone goes to rehab in a sense of physical therapy.
Yeah, I'm not staying.
No, it's probably, I don't know, 15-20% go to the rehab.
So it's possible to go home and.
Right. Most people want to do that.
Yeah.
And I would too. Yes.
Could this go somewhat negative side effects to that?
Well, once in a while people get a hypersensitivity reaction, particularly with the Synvisc, because it's got the animal protein in it, and they just get this painful reaction. No. And that's the advantage of it. It doesn't seem to have any bad side effects, long term.
And do that,
mild, moderate, severe, are there any stages, can it be done in severe osteoarthritis?
No, usually it's not as effective then. So it's usually, I use it when people, I see like a younger adult, you know, in the early stages of arthritis. That's when I typically use it, and that's where I find it works the best.
Use what?
The Synvis, or the Euflexa. Yes, sir.
What are your thoughts about robotic surgery for knee replacement?
Well, it's probably something that has a future. Right now, it's not there. There's been interest at varying times about that and using computer navigation, robotics, and to date, they haven't showed any clinical superiority. They're vastly more expensive. They take more time. And as a consequence, you know, the longer you're in surgery, the more complications you have. So they're probably something that's in the future, but they're just not a practicality right now. Yes?
How willing are insurance companies to pay for hip replacement surgery? Does it depend on the carrier, or does it depend on quality of life issues, or sort of what's behind everything?
I've never had a problem getting somebody, you know, on the schedule for that, but my understanding is that Medicare is going to be looking more closely at that, and they're going to want to have specific documentation. I feel like, I have a sense of when someone needs to have their surgery, but if I don't have everything just well documented, they're either going to deny it or they're going to say, sure, do it, but we're not going to pay you for it. So that's going to be something in the future that I really have to be very careful about. You have to document that they have the disability and the arthritic changes and the failure of conservative measures, things we talked about. It's all about documenting, what you've done. So they're going to be more careful, more looking at that.
How about private insurance carriers?
Well, usually they to some degree follow Medicare. So if Medicare gets something going, they're going to want to get on the bandwagon. Okay.
Did I miss how long you said that a hip replacement lasts? I think somebody asked about it.
Well, I tell people 20 years at least, maybe longer. Yes.
Can you use adult stem cells to put cartilage into your knees? I've heard that can be done.
Yeah.
It would be like my stem cells for me.
Those sort of things are probably good if you have just a very focal area of wear. Usually when you have arthritis, it is due to a lot of factors, your overall body alignment. And you can't, if you just address this one little area of wear, those abnormal mechanical forces are still operative. And so that's why doing a joint replacement is so successful, because we actually changed the alignment. We changed not only the surface, but we changed the mechanical forces acting on the knee, which you don't do with just a local application of something like that. So that's helpful, say, like in a younger person who has just a focal area, like a divot or a pothole, and sometimes people get that in the joint lining. And then you can do various strategies to try to regrow those cells. But in the typical arthritic process, it's not applicable because there's so many other things that are operative in developing that arthritis. You need a more comprehensive solution. Alrighty. Well, those good questions. Thank you.